Hi, I'm Dr. Stephanie Coulter, and I'm pleased to present to you the rise in non-atherosclerotic vascular conditions. It's time to consider fibromuscular dysplasia and spontaneous coronary artery dissection. So here is a list of the most significant arterial pathologies, and at the bottom of the list is the least common, but a very important arterial pathology that we need to talk about because it's becoming more evident. So fibromuscular dysplasia is actually kind of known as the string of beads sign on vascular imaging. You can see that there are the three layers of the artery on the top right little schema. Shows the intima, the media, and the adventitia, which are the three layers of the artery wall. And fibromuscular dysplasia is an abnormality, really primarily of the media. And you can see the abnormality in the lower box that shows, again, that string of beads, funny view that we're going to talk about. So when we talk about fibromuscular dysplasia, we need to define it. It turns out it's a non-atherosclerotic, it's not inflammatory, and it's a disease of the small and the medium arteries that lead to aneurysm, dissection, and importantly, arterial tortuosity. So importantly, the most common form of fibromuscular dysplasia is medial dysplasia, which really accounts for the lion's share of FMD. And this is importantly defined originally by histopathology, but now it's really defined angiographically because we don't have histopathology because these patients are walking around doing well and they don't come to surgery or necropsy. And so we're relying on angiographic standards to make the diagnosis now. But importantly, the two are related on this graph that shows in medial dysplasia that there's a multifocal string of beads appearance with tortuosity that's seen on angiography or by Doppler or CT angio or by MR angio. And there's thinning of the media, there's a loss of the internal elastic membrane, and there's thickening of the fibromuscular ridges. A less common variety is intimal fibroplasia or adventitial fibroplasia, which shows up as a focal or tubular stenosis, which has concentric collagen in the intima and leads to focal or band-like tubular stenosis, or sharp tubular stenosis in the least common adventitial fibroplasia. So the clinical manifestations of fibromuscular dysplasia, importantly, epidemiologically, it's a disease mostly of females. It's characteristically been associated with younger females, and that's what we teach our medical students, but in fact, it's not accurate. In fact, the average age at diagnosis in a female is about the age of 52 across all countries and all study surveys. About 90% of fibromuscular dysplasia is diagnosed in females. The manifestations are clearly related to the vascular territory involved at diagnosis, and the most common vascular bed involved is the renal, with 75 to 80% of the patients diagnosed with renal abnormalities. Then next in line is extracranial cerebrovascular arteries. That includes the vertebrals less commonly than the internal carotids, and cumulatively, the extracranial cerebrovascular abnormalities are found in about 75% of patients. So clearly, multiple territories are common and are found in at least 2/3. When we talk about coronary artery abnormalities, we're talking about less than 1% of patients who present with acute coronary syndrome. So it's quite uncommon to have an abnormality of the coronary in this discussion. The manifestation of the vascular injury depends on what's going on in the blood vessel wall. So it can lead to ischemia and occlusion. It can lead to dissection. It can lead to rupture. and less commonly to embolization. So here you can see what arterial dissection looks like in the left little cartoon, where there's a tear in the wall of the artery, allowing blood to separate into the wall layers, and it's most common in overall risk strata in the aorta, but in SCAD or in FMD, it occurs most commonly in the coronary arteries, the vertebrals, the carotids, and less commonly for dissection in the renal arteries. In arterial aneurysm, you have a bulging of all three layers of the artery wall, and you can see in that schema with the string of beads that where there is outpouchings in that media that's weakened, it can lead to aneurysms. Stenosis occurs when the artery wall is compromised, its flow, particularly due to dissection or intramural hematoma. So here the symptoms of fibromuscular dysplasia are related to the territory of the artery that's involved. And so if you look at all comers, headache is the most common. Next in line would be pulsatile tinnitus, which is a condition in which you can hear your heartbeat. And people come to the doctor, actually I just saw a patient with this, come to the doctor complaining of, I can hear my pulse in my ear. And it's usually unilateral. They also complain of neck pain and flank pain. And you can see there's a difference in the reporting of these symptoms between females and males. Certainly males are very uncommon for fibromuscular dysplasia, and the predominant line share is in females. The signs of fibromuscular dysplasia are hypertension because of renal artery stenosis, and that leads to resistant hypertension that's non-amenable to drug therapy and actually can lead to an atrophic kidney, lead to renal failure. And certainly when I see somebody with a history of renal artery stenosis, any worsening of the blood pressure tells me that they've got a recurrence. So hypertension is an important sign in both males and in females. The cervical bruit is found in about a quarter of participants in these registry trials, but it's clearly more common in females. Strokes occur in about 8% of the participants and TIA about 10%, but importantly, these registries are underrepresenting those that have no symptoms or signs. And in fact, 4.4% of asymptomatic kidney donors have angiographic evidence of fibromuscular dysplasia, which tells us that we are really undersampling how much fibromuscular dysplasia is out there. And now with more ubiquitous imaging techniques and more awareness, we're picking up fibromuscular dysplasia in asymptomatic, non-stenotic arteries in patients more commonly these days. So here you can see in a registry of 921 patients in the U.S. registry for fibromuscular dysplasia, about 42% of these patients that have referred or been referred into this national registry have experienced an aneurysm and or a dissection. About, 58% of patients have no dissection and no aneurysm and have just been found to have FMD and have been enrolled in this registry. The pathogenesis of FMD is really quite unknown. Certainly hormonal influences are playing a very large role, as we've seen fibromuscular dysplasia diagnosed mainly in women, 90%, and certainly perimenopausal and pregnancy tends to be a trigger for events. Genetics, we think, plays some role. Some whole genome sequencing and targeted sequencing has shown that the prostaglandin receptor gene variants, which are important in vascular remodeling, have been potential targets and have been shown to be abnormal in certain registries of FMD. A single variant mutation, which is the phosphatase and actin gene regulator, has been found to be abnormal in both SCAD patients, some coronary artery disease patients, and in patients with cervical dissection. The treatment and the follow-up for FMD includes a baby aspirin for life. Importantly, we don't recommend routine imaging any longer for vascular territories after the index pan body scan, especially if patients are without symptoms. It turns out when you are diagnosed with FMD, we recommend a scan of all the way from the brain into through the pelvis of the arteries by either CTA or some imaging modality. Really, we recommend CTA. And if you don't have evidence of FMD in a territory that's been scanned at your index event, then you're probably not going to develop FMD in any of those artery beds, and there's no reason to continue to scan routinely. Conservative management is certainly the treatment goal, and we wait for signs and symptoms. So invasive treatments, when necessary, are recommended, but really we recommend only invasive strategies if there's critical ischemia or a sudden event with very, very poor blood flow. If possible, we recommend the lowest injury to the blood vessel wall, and we recommend plain old balloon angioplasty for renal artery stenosis for fibromuscular dysplasia, and the same in the extracranial blood vessels, but certainly every now and then aneurysmal clipping or coiling is required, but stenting is reserved because stents are another potential injury to the blood vessel wall, and we certainly don't want to cause a dissection. So the FMD registry in North America is laid out in this diagram of the map, and you can see we're quite proud members of this FMD registry, and we've been members for about 1 year now. And you can see we're really the only one in the Southwest, and so we're getting more interest in our center, and we're looking forward to participating in the registry. And it's been a very good episode for us to participate. Here you can see that in this schema, you can read, if you have time, that the registry is recommending pan-body CT from the brain all the way to the pelvis, at least in your index admission or screening. Here's an advertisement that we've put out that's actually in Spanish, and so we have full access to Spanish-speaking moderators of this program here in our study here at the Texas Heart Institute. Here's a sample of what the new patient inflow workflow looks like. Now we're going to move along to spontaneous coronary artery dissection, or SCAD, as it's called. And SCAD is a non-traumatic, non-iatrogenic, non-atherosclerotic, it's a lot of nons, coronary artery wall disruption. In the upper cartoon, you can see the displacement of the intima and a tear as the intima is peeled off the media, which may spiral all the way down an artery. False lumen becomes filled with blood, and you can see that in the lower segment, where the true lumen, which is white, is much smaller than the false lumen because blood clots in the false lumen and tamponides off the true lumen as it fills with clotting blood. So this is what leads to ischemia and possibly to occlusion of a coronary artery in the setting of SCAD. So most SCAD events are associated with clinical presentation of chest pain in women predominantly without traditional risk factors for heart disease. So in fact, the incidence of SCAD in about 13 million acute coronary syndrome patients in America found in this survey only about 0.5% of the patients enrolled had SCAD. So it's quite uncommon, and it's sometimes hard to diagnose. Of note, you should be concerned if you've got an acute coronary syndrome in an early postmenopausal female without traditional risk factors. So it looks like a person that shouldn't have atherosclerosis. About 57% of the SCAD patients are actually postmenopausal females and not peri or early in their life women. SCAD is actually present as a cause for acute coronary syndromes in premenopausal women under the age of 50 in a quarter of the cases. So it should be a high level index of suspicion when you have a woman who's under 50 with an acute syndrome without traditional risk factors. And if you think SCAD's possible, it's going to change how you're going to manage this patient. The Canadian SCAD prospective cohort looked at 750 women, mostly, average about 88% female, average age 52 years of age, but 9% of the women in this cohort were over 65 years. So it can occur in older women as well. Males with SCAD had less extensive dissection and also had some atherosclerosis. So it's not clear, is this a separate entity in males? Because in women, we almost never find atherosclerosis. In fact, for all of my SCAD patients, I send them for a coronary calcium score just to see if they have any demonstrable calcified plaque. So if we talk about what are the predisposing factors for SCAD, certainly fibromuscular dysplasia is found in 70 to 80% of patients who have SCAD. Of note, postpartum status and multiparity, more than 4 prior pregnancies, increases the risk for SCAD and have been found in about 2 to 18%, depending on the registry that we look at. Connective tissue disorders, which include Ehlers-Danlos syndrome, most commonly, Marfan syndrome patients or Louis-Dietz are very rare. Certainly systemic inflammatory conditions have been shown in early registries to be associated with SCAD, but hormonal therapy with high doses of hormones for gender reassignment, for IVF, have been shown to be associated with SCAD. Of note, migraines are common in women who have SCAD, occurring in at least 40 to 50% of patients who present with SCAD. You can also see across different registries how common FMD is in women with SCAD. So it's variable, and it's variable by which group has scanned these women, but certainly we're very interested in scanning any SCAD patient for FMD with head to pelvis scans, mostly by CTA. Another important risk for SCAD, it turns out, is found in FMD and in SCAD, and it's tortuosity. And tortuosity of the vessels includes this definition, which is over 3 curves in an artery with over 90-degree switch. And in fact, tortuosity by this standard was found in 78% of the SCADs, but in only 17% of the controls. So what triggers SCAD? Well, it turns out emotional or intense stress by exercising is extremely important. In fact, I was going over this lecture with my young student today, and he reminded me that we'd seen a SCAD patient on Tuesday who'd had a terrible emotional stress where her boss had almost fired her for deleting files from a law firm, and she had a terrible stress, so terrified that she was going to lose her job and couldn't find the files, that she had stress, terrible, and chest discomfort for 3 days before she sought care. Of note, intense exercise, particularly with lifting and pushing, over 50 pounds has been associated with SCAD in about 10% of the cases, and certainly this intense exercise is more common in the males who've had SCAD than in females, but I think that may just be because males are more routinely involved in intense activities. Certainly hormonal triggers are important as the inciting events, and it can be either endogenous, like from pregnancy, or it can be exogenous, like IVF or high-dose hormone replacement therapy. Of note, the pathophysiology, or what causes SCAD, is really quite unknown. Certainly, we do believe that hormonal influences are important, and we think genetics are probably important as a risk, but when we ask family members if they have a history of SCAD, then it's only 1.2%. Whole genome sequencing has found in 85 SCAD families and 296 controls a variant of the TSR gene to be important. And again in SCAD, we found this phosphatase and actin regulator gene, which is a potential enhancer for the endothelin gene, has really been the first genetic risk factor for SCAD identified in the largest study of SCAD. And this genetic link may contribute to the clinical overlap between SCAD and FMD. And I wanted to finalize this presentation with just showing some pictures of what SCAD looks like. And on the left, it's the more typical SCAD, where you see an intimal flap and then this double lumen you can see at the arrow. And this occurs in between 45% and 50% of the cases. So this is one where it's kind of obvious that there's a dissection in the artery. Unfortunately, on the right, you have about 50% of the cases that have a long stenosis that you don't see the double lumen, but you see a very long tubular stenosis, and then you see reconstitution of the artery distally at a similar size as the earlier artery segment. And this should provoke you to think that this really is SCAD, especially in a woman or in a man with no traditional cardiac risk factors. Of note, when we talk about the treatment for SCAD and for FMD, we recommend aspirin lifelong for either FMD patients and those with SCAD. For those that have flow-limiting lesions, we recommend the least invasive trauma to the artery, because the artery is already fragile and friable, and putting more metal into an artery may actually cause further dissection, and you may actually take an artery that has TIMI flow and lose the TIMI flow as the vascular dissection worsens, and bleeding in that media with the vasovassorum can make it worse. So conservative management is strongly advised. This is why having a high index of suspicion for SCAD is super important when you take the patient for angiography. In fact, over time, dissections will heal in between 75 to 98% of the patients over a 2-year follow-up. So in a prospective study followed for SCAD and MI, 83% of the patients were conservatively managed and 16% required PCI, mainly POBA, or plain old ballooned angioplasty, for critical distal ischemia, and follow-up was done over 3 years. In this cohort, major adverse cardiac events occurred in 20% of the patients, death occurred in 1.2%, but recurrent MI occurred in 17%. Stroke or TIA occurred in 1.2%, and revascularization in follow-up was required in about really 3% of the population. In this study, recurrent SCAD occurred in 10% of the population, and this was increased by high blood pressure and decreased by beta blockade. Management considerations really mean this. Early angiography should be considered in acute coronary syndromes to exclude SCAD in otherwise low cardiac risk patients to ascertain how severe is the distal bed at risk and how much flow is there. If there's uncertainty about the angiographic presence of SCAD, then intracoronary imaging with optical coherence tomography, or IVUS, is recommended. Whole body imaging should be obtained to look for other arteriopathies. We recommend no weightlifting over 40 pounds. People are quite surprised by this, but isometric weightlifting causes an elevation in the blood pressure and puts tension on the arteries. We also limit upside down yoga. We recommend no roller coasters or spinning, recreational activities. We recommend beta blockers and aspirin for life. And I'm going to conclude my presentation today and wish you guys a happy day. Thank you.